All right, thank you for joining Person-Centered Services Engagement Series session on multiple diagnoses. What does it mean? My name is Amy Albanese, and I'm the Community Relations Manager with Person-Centered Services, and I cover our Eastern 10 counties. And we always start with our mission, vision, and core values. So Person-Centered Services provides health home care coordination for over 17,800 people with intellectual and developmental disabilities in 18 counties, reaching throughout the Western New York, Finger Lakes, and Southern Tier regions. Our mission is to connect people to the care, support, and opportunities that maximize their quality of life. Our vision is a community where all people lead fulfilling lives, and our core values are people, integrity, and trust. So next, we're going to quickly talk about our upcoming events. So we have prepared our 2025 engagement series sessions, starting with What is Access VR on January 14th. This is the only session we are unable to record, so we highly recommend joining the live session. And then in April, we'll have How to Be an Effective Advocate. In August, we'll have Supported Decision-Making and Alternative to Guardianship. And in November, we'll have Bullying and Youth with Special Needs. Now I'm going to turn it over to our presenter, Desirae.
Hi, everybody. Thanks for joining us. My name is Desirae. I'm a clinical specialist on the Person-Centered Services clinical team. I cover all 18 counties in our region. My primary role within our agency is to provide support and consultation to care coordination teams, so I can provide some education, guidance, and resources really to promote overall well-being for the individuals that we support. So this is our agenda for tonight. So what are we talking about? I'll give you a couple of definitions to start it off. Then I'll talk about multiple diagnoses in people with intellectual or developmental disabilities. Then we'll talk about overshadowing. I'll give some takeaways and strategies, and then I'll provide you some resources if you want to look into some things later on. So what are we talking about? So what is a diagnosis? A diagnosis is the art or act of identifying a disease from its signs and symptoms. So signs, this is what others see or observe, or what we have observed about ourselves, or changes in our pattern or our behavior. So maybe I've observed that I'm sleeping more or less, or I've observed that you are sleeping more or less. And then symptoms, so this is what we experience internally and physically. So maybe I'm experiencing some depressed mood. You may or may not see it, but it's something I'm experiencing. So what type of diagnoses are there? So there are medical, clinical, mental health, and substance disorders. And who can diagnose these? Well, it really depends on what's being diagnosed. So maybe a doctor, psychologist, or etc. So understanding some biases and myths. So people with developmental disabilities often exhibit aggression or self-injurious behavior. They can't experience human emotions like you or I. They don't develop depression, personality disorders, or other mental health disorders. They can't feel oppressed by their dependence on others. They can't benefit from mental health, behavioral health, or substance use treatment. Medication is the only option. They are just attention seeking and should know better. And they're just behavioral, when we could fix bad behavior by punishment and consequences. So I've heard most of these at some point or another throughout my career. It's likely that you've heard it, thought it, or know somebody who may think in this way. Some people do believe these things to be true, but these are all incorrect. So multiple diagnoses in people with ID or DED. So multiple diagnoses. So this is really a better way to talk about dual diagnosis or comorbidities. Really, when you say dual diagnosis, it kind of implicates that a person's behavior can really only be attributed to one diagnosis or the other. But a person can be diagnosed with more than one thing at a time, but really they could be diagnosed with both developmental disabilities and or medical conditions and or mental health conditions. So here's what we see with people we support here at Person-Centered Services. So 14 out of 256 high utilizers have one diagnosis. 95% of those have more than one diagnosis, and many have more than 3. And just for clarity, a high utilizer is considered somebody who might go to the hospital 2 or more times per month. So here's what we know. So people with developmental disabilities are likely to be diagnosed inaccurately or unnecessarily with some disorders. So for example, there's a notable percentage of individuals with disabilities that may be diagnosed with a psychotic disorder. But these symptoms can really be better explained by something else. Another example, maybe somebody with autism may be verbally responding to somebody, but no one's actually present. Someone may see this and see it as a hallucination, but in reality, maybe they're just talking to themselves, or maybe they're trying to process the voice that they hear inside of their head. We also know that people with developmental disorders are likely to be diagnosed with some significant or less likely to be diagnosed with significant disorders that are actually present. Trauma-related disorders are something that's often overlooked. It's not uncommon to read someone's records and notice they have experienced some significant abuse in their life. So they may be displaying some externalizing behaviors, maybe like physical aggression, but often the trauma receives very little attention. So we also know that the complexity of signs and symptoms and behaviors might make it difficult to tease out underlying concerns. So there are a lot of conditions that do share similar symptoms. Like a simple example, thyroid disorders often mimic mood disorders. We also know that a person who has a parent, sibling, or grandparent that is diagnosed with a mental health challenge could develop same or similar diagnoses. And this is similar for medically related diagnoses. But we always want to advocate for the ruling out of medical and physical complaints when another path is not clear. So overshadowing. We really want to be aware of overshadowing, but what is it? It's a phenomenon in which all signs, symptoms, or changes are attributed to a developmental disability or to a mental health disorder without due consideration of other possible causes. And this phenomenon really occurs too frequently and in all settings. So why does this happen? Maybe it's a lack of formal training or bias or stereotypes like we talked about on the previous slide. Maybe some tunnel vision, right? Where you're only focused on one thing or one diagnosis without really looking at the bigger picture or the smaller details. So maybe there's a lack of available information. So a physician might not have a full history or don't know the person well enough to accurately assess what's going on. Or maybe they just have limited exposure to a specific group of people. They haven't really worked with anybody with autism before, or they've never worked with anybody with bipolar disorder. So what does this look like in real life? So just a couple examples. So example 1, a nonverbal child diagnosed with autism has started to become increasingly aggressive towards others. He's also been hitting himself in the head and chewing on non-food items. But this is just how he is. This is the autism, right? So family might take him to the doctor, and they prescribe him some medication to reduce agitation. Maybe the school move him to a more restrictive setting to focus on behavior reduction instead of academics. But at the end of the day, nothing is effective and he's still exhibiting these behaviors. But suddenly one day he spikes a fever and goes to the doctor or the hospital, and come to find out he just has a tooth infection. His infection gets treated and he returns back to normal. But everybody assumed it was a behavior associated with autism instead of looking at the signs. He was communicating that he was in pain, but because he's nonverbal, he had to find another way to communicate this. So example number 2, a young woman with a mild intellectual disability has started exhibiting strange behavior, as well as talking to people that aren't there. She's been pretty agitated and not really acting like herself, when her support system is concerned that she's experiencing a mental health crisis. So her family and her providers, they all meet to try to figure out how they're going to best help her. So they made some decisions, and family made an appointment for a psychiatrist, care coordination starting referrals for residential placement. And not long after, her roommates are pretty concerned about her, and crisis services is called. So they end up transporting her to the hospital, and the hospital's working to medically clear her before they transfer her to CPAP. However, during this, they determine that she has a urinary tract infection. So her UTI gets treated, and the referrals to psych and residential are no longer needed. But her team put a lot of effort into these treatments and supports, but it really wasn't necessary in the end. The primary focus here was really on the emergence of a new mental health condition, but they didn't rule out any medical conditions first. So these are just a couple situations that I've seen in my position, and I could probably honestly give you dozens more. They really show how physical health conditions can be easily overlooked when the focus is solely on a person's mental health or their developmental disability. But physical health conditions aren't the only thing that can cause a change in behavior. This can also come from different life circumstances as well. So maybe there's a change in the person's environment, or maybe they're just experiencing some grief, sadness, or loneliness. I always recommend ruling out medical first, but you do want to take into account some external factors in a person's life that might be causing them to behave a little differently than their normal. So how does overshadowing harm the people we support? Well, a person's needs and experiences might not be taken seriously. It can result in an inaccurate diagnosis and treatment. They can also contribute to prolonged suffering and unnecessary strain on the person and their support system. So as you can see in the example I gave, the child experienced pain and discomfort over a period of time because the main focus was on his autism diagnosis. We also see a lot of individuals lose faith or trust in their support system in situations like this because they feel like nobody's going to help them, and that causes additional distress. And it also perpetuates stigma and mistreatment of people with developmental disabilities. So how do we reduce overshadowing? Well, first you want to become aware and pay attention. You really want to acknowledge that overshadowing occurs on a frequent and regular basis. We want to accept that people with developmental disabilities experience the same mental, physical, and behavioral health concerns as those without developmental disabilities. We have to understand that people with disabilities can experience loneliness, low self-esteem, sadness, rejection, loss, disappointment, fear, trauma, and all other human emotions that are difficult to cope with. You know, all people struggle with human emotions, and people with disabilities aren't immune to these struggles. We also want to advocate for accurate and thorough assessments and examinations to arrive at an accurate diagnosis. So just continuing with how to reduce overshadowing, we want to understand that sometimes signs and symptoms of clinically relevant concerns might appear differently in people with disabilities. So I may be able to tell you I'm feeling anxious, or I can describe feelings of anxiety, but this requires insight and the ability to label feelings. And maybe for someone with a disability, they might not be able to do that. So it's possible this anxiety might present maybe as rumination, right? So they're asking the same question over and over and over. So maybe they're seeking comfort and confirmation to ease the symptoms of the anxiety that they're feeling. And we really want to understand that all behavior is a sign or symptom. It serves a purpose and or it's communicating something. And that's whether it's verbal or nonverbal. So everybody communicates through behavior, even the simplest ways, right? An infant cries when they're hungry. Maybe I yawn when I'm bored, or I fidget with my hands when I'm anxious. And it's important to recognize when someone has a change in their behavior. Like maybe they used to sit with their housemates and watch TV after work, but now they spend that time in their room. So they might be communicating something, even if it's not obvious. We want to provide professionals with neutral, detailed, and accurate and unbiased information. And we really want to pay attention to changes in a person's medication, environment, circumstances, behaviors, etc. So maybe someone's medication dosage changed and they've been appearing a little more fatigued than usual. Or maybe someone's isolating themselves more, but it's just because they don't like their new roommate very much. You always want to take note of any changes in a person's life because this could really give you the reason for a change in their behavior. So takeaways and strategies. So just some key takeaways. Overshadowing may impact accurate diagnoses, but accurate diagnosing can take time and many people. So if you're recognizing something, but maybe a physician won't take it into consideration, you want to get a second opinion. You want to do some research or talk to a professional that has experience in that area. You really want to advocate for and be a voice for the person you're supporting if they're unable to do so themselves. So care coordinators and most other service providers cannot diagnose, but they should always be advocating for accurate, thorough diagnosis and treatment. Like I said before, you always want to rule out medical issues and concerns first if possible, because physical ailments can present as or even cause mental health symptoms, and alleviating these physical symptoms could in turn alleviate the psychological ones. You want to make sure you're not getting caught up in the chicken or the egg thought process. So really, that just means don't focus too much on what was diagnosed first. And then the last takeaway is people with disabilities should not be excluded from traditional talk therapy, group therapy, or substance use treatment automatically. This is really case by case and should be part of the person-centered planning process. So just some strategies. You're going to want to provide the person with information about their diagnoses in a manner they can understand. So maybe they learn better through written communication or even using visuals, but you're going to want to provide the information in a way that they can understand, because it'll ultimately help them understand themselves and advocate for themselves. They might even be able to recognize any new symptoms that they're internally experiencing. We're going to want to be mindful of any changes in a person's behavior or well-being. And like we said before, all behavior serves a purpose, even if the behavior is not purposeful. You're going to want to openly communicate with everyone involved in a person's life, so doctors, caregivers, service providers, etc. Many psychiatric conditions are cyclical, so tracking symptoms and signs, coping strategies, and length of episodes is really helpful for the treatment team. This could also help to identify patterns of behavior that might not even be associated with a psychiatric condition. So maybe somebody's behavior is different every Tuesday and Wednesday before they go to program. But ultimately, maybe there's just something scheduled on those days they just don't like and they don't really want to go. And lastly, you don't want to downplay the impact that trauma can have on a person's overall health, specifically their mental health. Trauma can really cause a person to react in a variety of ways, physically and mentally. And roughly 70% of adults in the US have experienced some form of trauma. So you want to make sure this is being considered when you notice any change in a person's behavior. And then here are just some resources. You could take a look at those and we'll give you a second to write those down. Okay, and then on the next slide, that is my contact information. I'll also give you a minute to write that down. You can write down my phone number or my email. If you do have any questions after this, maybe you're not watching this live, feel free to send me questions at any time.